I'm going to give everybody just a couple more minutes to either filter into the room. We have 5 folks here, or 6 with me and 27 online. So, and can everybody hear online well? If they...
Yep, sounds good.
Yes, we can.
And I just want to check in with some of our online people. Dr. Wong from University of Kansas, are you online? Or are you
Yes, I am.
Okay, terrific. And then Sarah Schiller, are you on?
I am, yep.
Awesome. All right. And then Dr. Chalmers, are you here? Okay, I'm not hearing him. He was going to be presenting for Dr. Yi. If you're just coming in. What? Oh, I'm sorry. I wrote the wrong name down for Dr. Johnson. I'm sorry. I'm sorry. I thought that was you. All right, no, we're good with that. If you're just coming in the room, there's a printed agenda on the back counter. So if that helps, and we will try to stick that as much as possible because we're having help in the back for some of our screen presentations. And then also too, when we're not presenting something on the screen, we can kind of show the all the participants that are online. So I'd like to thank everybody that's here in person. It's nice to see smiling faces behind masks and such. And it's definitely interesting to do a hybrid meeting like this. For those of you online that can't see, it's a fairly empty room, but the people here are very engaged. So, and also for you online, it's a little bit different when your welcome bag has a COVID test in it. So it's kind of a different experience. So this is our second meeting as a full committee. So that's exciting, and happy to see you here and know that so many folks are online and wanting to participate in this. So we're going to jump right in and start out with Dr. Wong. He's one of our VA representatives on the lung committee, and did a survey and has some comments about that lung committee participation. So if you'd like to start off with that. Dr. Wong?
Yes, are you able to see my slides?
Yes.
Okay, perfect. Yes, so thank you for inviting me to talk a little bit. So I'm a member of the lung cancer committee, and I'm also a staff at the Kansas City VA. And so I want to share some information about lung cancer within the VA system, and also the research within the VA system, and how the lung cancer committee can work with the VA to try to help improve accruals and design trials and so forth. So this is some information that was generated a few years ago. This was published in the Federal Practitioner in 2019, which essentially showed the majority of the lung cancer diagnosed in the VAs are either stage 3 or 4 here, as you can see, is the second most common cancer. And there's about 7,000 cases every year. The median age is about 68. And, it's 40% diagnosed with metastatic disease, and less than half of them receive systemic therapy. 86% had non-small cell, 14% with small cell lung cancer. And in our regional Kansas City VA area, the similarity is similar in terms of staging. So majority, again, 40% stage 4, and but looks like there's a prevalence of a squamous cell at 33% of them versus 29%. We have a multimodality available here: surgery, radiation, chemotherapy. But compared to some of the Commission on Cancer committees, institutions, patients with stage 1, they are treated more likely with radiation than with surgery. So I think it probably speaks to the fact that most of these patients have some type of comorbidities that don't allow surgery. They have to travel longer to come to the facility. For majority of them have to travel 50 miles or more. And majority of them, over 60%, had a Charleston comorbidity score more than 1. So these are probably sicker patients, have to travel longer to the VA and so forth. So in terms of numbers, I think the VA is a very rich potential partners to accrue patients for lung cancer. As you know, this is directly from the VA website. The VA health system is the largest integrated health system, has 171 VA medical centers. I think everybody here in the room probably knows about it. The VA has mandated lung cancer screening. So from that, there's a paper here that was published in 2020, in which they screened from the screening patients from 2011 to 2018 was about only about 2,000 patients. I think this number is bound to increase because approximately 900,000 veterans are eligible for screening. So early stage disease is probably going to increase significantly in the next several years as the VA ramp up the screening procedure. So if we have about 7,000 patients with lung cancers a year, and if we say that about 10% of them, ideally gets enrolled in clinical trial, that means about 700 patients can potentially be enrolled in clinical trial, which if 30% or so are stage 4 disease, there's about 231 cases that are potentially eligible to be enrolled in stage 4 disease. And that could potentially make a huge percentage of, for example, this Insignia trial that uses standard therapy. This is nothing, investigational standard drugs that is currently available in the VA health system that can potentially be just given to the patients if the trials was open within the VA health system. I asked the SWOG to give some numbers of how many patients the VA has accruing lung cancer studies, and I'm not quite sure if this is completely accurate. So the non-SWOG institutions here, you can see from 2011 to 2022, about 9 years, about 56 patients. I'm not quite sure if this is correct, but this is the number I was given. So from the VA side, this is VA accrual in lung cancer studies. The VA has done initiatives to increase clinical trial accrual. So back in 1997, there was an agreement between the NCI and the VA to increase accrual, to expand opportunity to open clinical trials in the VA sites. And more recently, in 2018, there was a Navigate grant that was given to 12 sites within the VA health system to increase clinical trial opening and enrollment. So in terms of trying to understanding how the VA can help, or what the VA needs for the lung cancer committee, I sent this survey to all the members that's in the email list that was sent out some time ago, inviting the members to participate in the VA committee and trying to understand some of the things in terms of what studies the VA side seems to prefer. Is it intervention studies or observational studies? And if it's intervention studies, which studies do they think that we should open? Is it neoadjuvant, adjuvant, concurrent, or first or second line trials? And then what can the SWOG Lung Committee do to help the VA sites to open clinical studies? And then what are the main barriers that the SWOG lung studies encountered by the VA sites, and what can the VA committee do to help the SWOG lung committee facilitate clinical research? So about 15 of the we had 15 people respond to me. So you can see here the majority, it seems to be fairly well distributed between Northeast, Midwest, Southwest. I didn't have anybody from Southeast responded to this survey. And in terms of what type of study, the majority thought that we should open both type of study, interventional and observational studies. Okay, there was a preponderance of 20% just says just interventional studies. And by the way, the responses can be multiple. So the person responding to the survey can pick up more than one answer. In terms of what type of interventional studies, looks like the majority, 78%, seems to prefer that we open first and second line and beyond in metastatic disease. And then after that, concurrent, and then adjuvant therapy, and then 5 respondents chose to be neoadjuvant. In terms of what can the lung community do to help VA open studies, the majority of them seems to check off this option to provide grants or hiring research coordinators. I think that's a big barrier in terms of trying to do clinical research within the VA sites. There's not really a lot of support from the administration for this. Then there is the involve the VA sites in the clinical trial design. That was the second most common response. And then to reduce regulatory burden from the SWOG in terms of the clinical studies. Some of the other responses here, they say provide more training, study coordinators, and I think that's one of the options. What are the main barriers from the SWOG lung cancer studies encountered by the VA side? The top one seems to be eligibility and exclusion criteria. So that's something I think, I think we very commonly would see protocols that, we think that we can accrue, but then there is this little eligibility or exclusion that say either PFT has to be, FEV1 more than 2 liters, and a lot of our patients are smokers, and therefore the patients are not candidates. So that's something that was the top reason that seems as a barrier. And then the second here, requirement of special labs or requirement of certain type of biopsy. And there were some other responses that some of the respondents were able to write in: lack of incentive for VA centers to accrue patients, other competing non-SWOG study, lack of radiation facility, time requirements for patients to get screened and enrolled in studies, and complex or very narrow timelines. We all know that sometimes we encounter challenges to try to get a CT scan done within a week or 2 weeks so the patients can go on the study. The other thing, what can the VA committee do to help SWOG lung cancer community facilitate clinical research? The top one is trying to see if we can reduce regulatory issue within the SWOG. So that was the one. The second most common was the device recruitment strategies for VA patients. And then there was training research coordinators. And I think the SWOG in the beginning of the meeting, there was a training program, and I actually asked our research coordinators to participate and to attend to that meeting to train how to deal with the SWOG studies and so forth. And then there was the increased communication between the SWOG lung cancer committee and the VA committee regarding any changes in the protocol and so forth. And then there's some other answers here. So I think in summary, what this survey is telling us, we have issues with clinical trials. Most of the VA seem to prefer to have interventional studies and then observational studies, preferably first and second line metastatic cancer. We should try to see if we can work on eligibility exclusion criteria to allow to devise and be more relevant for the VA population. Personnel seems to be something that came up often. If we can get grants to hire more research personnel, and I think there was something that was sent out recently. There was another potential grant that would be activated or released now for the VA sites to apply. Training certainly is something very common. Our center lost pretty much our research coordinators. We have to rehire new research coordinators, and training is an important part of that process to get them up to speed. And then regulatory issues, because of reduced personnel, a lot of the regulatory requirements, it's fell behind, and we have to get that up to speed and so forth. And then trying to reduce regulatory demands. So some of the things that we can see if we can try to discuss, try to improve, again, is it possible for the future the VA have a directive open clinical trials at the VA sites? They have demands. We have a directive to have cancer committee. They have a directive to have lung cancer screening. Why not have a directive to open oncology trials? Maybe not for obscure cancer or some rare sarcoma, but prostate cancer, lung cancer. Those are the very common cancers within the VA health system that I think we should be able to accrue without problems. And then access of known urban patients. Here in the Midwest, we have patients that travel long distance. So increased utilization with telehealth that can potentially be used to consent patients or explain the study to the patient, screening and so forth. Regulatory, is it possible to reduce the regulatory burden? I know a lot of the VA has their own local IRB. There is a central IRB for a lot of the studies, but even the process to get into the central IRB at our site, it took us over a year for us to get into affiliated with central IRB. Is it possible to have all VA sites who are already affiliated with a SWOG site to become a sub-site automatically, so we can get all those VAs to be able to enroll patients? And then the other thing that we encounter, and we had discussions in the past, this privacy and computer security issue, make it uniform and compatible with research. I mean, just to do this little survey, I've received emails that a lot of the VA side, they were not able to click directly on the link and do the survey because there was a block. So just simple things like that just make it harder. In terms of trial collaboration between the PIs who are devising trials and the VA committee to devise, to look at the eligibility, to see what's possible and what's not possible to increase participation, and then to, treatments that's compatible with the VA health system and procedures that's possible within the VA health system. It's probably not feasible to have navigation bronchoscopy in some of the protocols because not all VAs has that and so forth. So if there's a protocol that requires a navigation bronchoscopy, VA sites, a lot of VA sites probably won't be able to do it. And then again, funding, I think we have discussed that there will be a release of funding for additional VA sites to participate. So with that, I just want to share what Albert Einstein said: if we knew what it was we were doing, it would not be called research, would it? Well, thank you.
Dr. Wong, I had to relocate just so I could see the slides, but any questions or comments or things to fill in that Dr. Wong brought up about that? There was a lot of things that I know we've discussed in the past. We've tried to create some solutions for some of them to varying extents of success or non-success. So open up the floor both in the room and online. Are we getting chats or questions or comments that way, or can they just speak up?
The chat box is live.
Yeah. And I think they can just unmute and speak. I think that's probably going to be the most efficient for us. So anything from everybody online? Okay, well, I made a couple of notes. I think, a couple of important things that I think recruitment strategies within VA would be something that would be really great to kind of pursue as a group, as to what we can do to assist with that within the VA framework. I know SWOG's rolling out some things. I saw they had some social media templates that they're going to roll out, and some patient trial information sheets, but I think there's probably some other things we can do that might be a little more specific to VA and maybe also engage our rural partners a little bit more. I think we might have some advantages with the new PopCap and LPOP and all the different cancer groups that are being stood up within VA that are kind of using hub and spoke sites. So we might be able to take advantage of that as well to maybe to be synergistic with our SWOG trials. And I know like LPOP's, searching for trials to do. So certainly an NCTN trial might be the place to go with that. And as far as, dollars for CRAs and everything's always an issue. I think we're always trying to come up with ways to get those dollars. We'll talk about it a little later in the program about the VA storefront concept versus single site funding concept and how that might help with a couple of the things that were brought up in this presentation, which include regulatory burden and helping eliminate that, or at least minimize that to the extent that might be possible. Yeah.
So I know that two things that I think might, I don't know how many other VA sites are in the meeting, but I'm from Philadelphia, and we had one of our project coordinators, he was able to kind of like start the process and get through two different commercial IRB sites actually. One through Sterling for a trial we're running with Janssen, and then one I think specifically for SWOG, and it took a little bit of like, it seemed like we were starting from kind of square one at our site, but I'm sure that he doesn't need to know I'm sharing his information, but I can definitely share it to some of the other sites who are, and they kind of, if Philly's the model of how to do this stuff and make it work, then absolutely. Because even with the CRA funding, is that myself is that my position was primarily funded through PCF, because a lot of VA sites are Prostate Cancer Foundation Centers of Excellence. And then it's when we're on SWOG trials, it's just piecing out your hours to whoever your the contract organization you're working with is right? So that necessarily is there are definitely ways around it where SWOG doesn't have to be the front man for this. Right? SWOG doesn't have to say, okay, I'm gonna put down, $60,000 a year for the CRA. Usually there's other people who are willing to do that, and it's just kind of that logistics of moving it around appropriately and having, we're on the SWOG site, we can say maybe I have $3,000 that I can spend. Well, then that's X amount of hours this CRA can get out of it, and kind of going through it like that. But that's usually a lot of the importance of trying to find a really good contractor agency. So we have, it's called the Philadelphia Research Education Foundation. They're great at managing all of that stuff and kind of like making all of these things work seamlessly so that no one has to really worry about it behind the scenes. It's just ensuring that the doctors, the CRAs are logging their hours correctly.
Right. So yeah, I think that's probably, good that we could improve our best practices sharing, because I think there's a lot of solutions out there that just haven't been shared among others. Some have been and benefited from that. So that's something as a committee we can work on, and I will make a note of that, and we will try to find some ways and come up with some proposals, or if somebody has proposals of a good way to do that, please send it to us so that we can share that with you, whether it's, a SharePoint site. We do have the VA workbench, which we can share some of those things as well. That's on the SWOG site. And there might be some things that we should do internally with VA as well, because it might be some other non-SWOG things. Yeah.
We did stuff yesterday on the meet call that the coordinators for all the sites are putting on a put together manual of SOPs and things like that. And so I think that will be shared on the SharePoint. So it's how to do things, go through the NCI and the CIRB, and how to
Is that on the Navigate site?
I'm not, I think it will be on the Navigate site, but I think the intent is to make it shareable, you know, so that everyone can see it. And then we talked a little bit about sharing like position descriptions, because I received an email from one of the LPOP sites asking about position description for a research nurse, and we're not an LPOP site. And so we did share it, but it seems like that's kind of low hanging fruit that we shouldn't reinvent the wheel every time we're trying to hire someone.
Right.
Or open a study. So I do think that some good sharing will come out of the Navigate, you know, consortium that will be helpful to others trying to get through some of the logistics.
Yeah, can you guys hear online? Okay.
I couldn't hear very well.
No,
Sorry.
can't hear.
Okay. Yeah, just so that our remote folks can hear. Sorry.
So hi there, Cheryl Sterlanis from Heinz VA in Chicago. What I was saying is that yesterday on the Navigate call, we discussed that the coordinators are putting together a sort of handbook of standard operating procedures. And we had talked about sort of the sharing of other documents to help with the logistics of studies, so that we're not reinventing the wheel every time we try and hire someone or try and get patients on a study. And that information, the goal is to have that shareable on a SharePoint site that everyone could access. And I do think that that will help with some of the logistics, so that we can, you know, again, share some of the best practices.
That's a very good idea.
Yeah,
So in that vein, can I ask a question? So I am new to the whole SWOG world, but I've been a research nurse for a very long time and have done a ton of industry-sponsored studies. Do any of the other research nurses or coordinators find these protocols, the format of them, like hard to follow?
for the SWOG protocols, or
Yes.
um,
I mean, I feel like things jump around in them.
I don't, but I've been reading SWOG protocols a long time, and they kind of come all the same way. I mean, there's some of them where, I mean, you know what section to look in for drug information. So
Well, that's why I threw it out to the coordinators and the nurses.
yeah, does anybody else have any trouble following the SWOG protocols at all?
I mean, I feel like there's information in one section, and then you got to go down like another couple pages to find, and then there's something else related to that other part. And some kind of an inclusion, exclusion, that kind of a thing. Maybe it's me and I'm used to a different style of protocols, but I was just asking because I find the one we're doing confusing.
Okay, hopefully that's a one-off or something, but I think for the most part, the trial group puts them together in a similar format. So if you get used to it, the SWOG format, it's fairly.
So maybe, you know, she raised a point. So if there is a question on a study coordinator in one VA site, can we create some kind of even a group chat on the, you know, we all have teams. Can we create a teams to answer question? Hey, does anybody know about this protocol in SWOG? Does anybody have any experience? Because sometimes that is much faster than trying to search in the protocol and trying to read all the minutiae until trying to figure it out. Because sometimes I agree that in the protocol, it's not clear. And then you have to really read this and then go to the subnote and those so forth. But if somebody already know about this, if we just ask the group, does anybody know about this question on this protocol, and see what people tells? I mean, that sometimes is much faster than trying to figure out on your own. And sometimes
Well, I think that was my
correction.
point. Like what you're saying, like you have to go on to a different section
Yes.
for clarification. And if you look at the chat, apparently, thank you, people. I'm not the only person who feels like that.
Yeah.
I just, you know, the people that write them don't do the studies.
Yeah.
Not criticizing, just saying.
Right.
So,
So
I mean,
create some type of a teams within the VA system that people can just type in the question, and if anybody knows it, just answer it. And then that could be very quickly
But you're not the be all and end all in the chat. You know what I mean? Like that's up to
Correct.
SWOG to decide. So if
Correct.
SWOG made them easier to do that, then I mean, I think the teams is a good idea because I have not done any SWOG studies. So it's great to have somebody, you know,
Yeah.
West Haven's been helpful for us, but
Right.
you know, we can't just go by what a coordinator says because it's a protocol.
Right.
So I
Right,
think
and-
formatting
One
makes
of-
a difference.
This is the thing that you may run into though is that when you put it in teams, you don't know who's answering, and you have to have a source document from the study personnel who has the right to give you directions and clarifications on the study. So you're going to open up a big can of worms.
Right. I agree with
you
that
agree
totally.
with it. Yeah, and nurse, and what you said is correct. I've dealt with GOGs in the past, but the SWOG, here's a good example. I think it's still true, although our site does not practice. We're not a participant of SWOG trials at this particular VA, but standard of care practice is a separate booklet than what is written in the study. So not only do you have to reference back into the study, and if you're not used to it as a new person coming on, then you have to go and search for the standard of care practice handbook that gives you, oh, you could max out on your dose at, you know, a BSA of whatever, and it gives you have to go by a WBC or ANCs, and it's written in a separate booklet. And I think that's still true. You can correct me, but I think that's what you're referring to. It is very wordy, and it opens up a lot of can of worms for VA sites who's not used to cooperative group trials. That's NCI run or SWOG run and things like that.
Steve, this is Monica from West Haven. Can you hear me?
I can.
So I think in reference to what Karen was saying about the SWOG studies being hard to follow, we've been involved with a few of them, and I find them the most difficult, I think, to follow, even though we've done a few of them. And I think one of my biggest complaints, and not just me, some of the other coordinators at our site, when you go to look at the footnotes in the study calendar, they are just, why are they not just labeled like A, B, C, D or 1, 2, 3, 4? They have all these symbols. I find them confusing no matter how
Preach,
many
Monica,
times I've done it.
preach.
Yeah,
I
I mean,
agree
it's
with that.
not something you're gonna fix. I'm just, you know, letting off a little steam here because I agree with Karen, and I just feel like no matter how many of these we've done, I don't know what it is why I get hung up trying to figure out where stuff is, even though I know it's all in the same area. I feel that some of the other cooperative group protocols seem more logical to me in the way that they're set up. And I know we're not going to change how SWOG is setting them up, but it's just, I don't think
But
that you need to feel like you're alone trying to figure it out.
But it's good to know. I mean, I have devised a protocol recently, and some of the protocol writing is based on a template. So if people are having trouble reading it, then I will certainly go back and tell them the next time I have a protocol and say, hey, we need to change this so it's easier to read. And there's no need to make it so small. Why can't it be the same font size?
Exactly. Yes,
Because people need to
especially
read
for
it.
those of us who now are wearing, you know, bifocals, progressive
Right, people need
lenses,
to read
etc.
it.
I
So
can't
if
even
you-
read it.
This is
Would you be
This is
willing to have
Caitlin.
some of us sign up to help you with that? I mean, I used to help write industry sponsored protocols. So I'm happy to help out if it makes it easier for me and everybody else. I know there's a template, but
I think it would
The
be good
protocols
maybe.
are written by
Go ahead.
people who don't do
there's
the
a group
studies.
that does that. It's not going to be us that can, I think.
But we can maybe suggest to the
Yeah, well, I think
writers
we
of the
give
protocol.
feedback as to, you know, this is hard to understand or hard to read, or make it bigger. But
This,
This is
Steve,
Caitlin in Denver, and I think that this also speaks a bit to like the power, what was suggested before with using teams, the benefit, although I think that the
kind of caveat being lead source. I completely agree with those statements there. Having teams is a really powerful tool. We're part of the Navigate group here in Denver, and we use that to help not clarify protocol steps, but troubleshoot in other capacities. More on the VA side, less protocol specific. And I think what this really all illuminates is that we need a push for consistency across sites from a regulatory angle. I know that this is kind of the hill I will die on within the VA, because I know that there's a lot of variability, and some sites have a really, easy pipeline to research. Others, it takes 2 years to open a study and early hinders enrollment. And I think a lot of it comes down not just to engagement of local research departments, but of consistency across VA sites. We've made the transition to VAERS nationally. I think that helps some, but I still think when I sit and have calls with the other Navigate sites, there are things that they know and do better and are easier because everyone has different red tape at each site. And the more consistent we can be from a regulatory process, the more united we can be tackling the minutia too, because we can all see and interpret things the same way, and then push back towards, templates being changed, et cetera. So I think that a big thing we can do is if we can simplify and, make all sites have more similarities in their process, it allows for us to implement things like a national handbook for coordinators. We have a beta version of this just within our Navigate group for NCI trial, everything from development to execution for a coordinator to do their job within the VA. We have a 200-page handbook, but it's challenging to implement something like that when every site has its own rules. We can implement it locally and tweak it, but it'd be great to see that kind of come to fruition. I think that would help with efficiency and with recruitment at the end of the day.
Yeah, I think we could do a Teams or even a listserv or something like that. Again, with the caveat that, you can't make official protocol determinations from that, but you can share solutions to common problems and ways to do things, or just answer kind of broad questions that might be, plaguing you, that or point you in the right direction within the protocol or other places. So we can definitely work on that. And I think one of the things about that is it's almost as if VA has gotten almost more fragmented with this, because we have SWOG, we have LPOP, we have POPCAP, we have Navigate, we have NRG, we have, Alliance. So it would be nice if we could kind of all share like general best practices. It doesn't necessarily need to be protocol specific, but more process related within VA, and maybe lean on ORD a little bit to help maybe the less the sites that may have some regulatory hurdles presented to some of our study teams that are really unnecessary, that are just kind of hanging on to some old rules and ways of doing things or turf or whatever it might be, because that's not benefiting anybody in the long run. So any other comments on that? We kind of need to move on with a couple of other things on our agenda. We can come back to that if we have time. But any other burning comments? All right. In terms of the actual committees we have, there are openings on a number of the disease site committees that anybody in the room or online, they're listed in the agenda, and it certainly seems like there's a couple of these that would be really important for VA, GI, prevention, epidemiology, and palliative end of life. There's others as well, but if anybody's interested in becoming a VA representative on those protocol committees. And I think, if you're on those protocol committees too, that's a time to really, you can certainly suggest improvements in the protocol process and clarification. And certainly one of the other things that Dr. Wong mentioned, that, the inclusion exclusion criteria, so it doesn't exclude anything, as one of my former oncologists in Denver used to say, everything but movie stars. So you certainly help in that case. And so I think we're going to have, hopefully this process of including a VA representative on these committees will be helpful.
So how do we get on these committees?
You have to apply. We have a process. It's been a while since we've had to do that, since we've done the first round of these. But we can send out that information to the group, and also what openings are available.
So would you guys be willing to modify your template then to make it easier for the people that are using the study protocols?
I don't think that's for us. I think we'd have to talk to the SWOG operations office. That's kind of not us.
This is Annette Bentley. Yeah, I would recommend that they contact or bring in Dana Sparks into that conversation.
Right. Yeah, that's a bigger discussion than VA. But certainly, I think we can always make. Speaking of Dana Sparks, she walked in the back. So somebody's ears were burning. But yeah, we can, talk about that, about how to improve readability and usability of the protocol.
I mean, you could send out a survey and ask all the, a bunch of sites how they feel about it. I mean, there's 3 or 4 of us here that are saying we don't find them easy to read, so we can't just be the only. I'm not trying to be difficult. I'd like to do the job and do it correctly and give you the right patients for the studies.
Yeah, so we can talk about that. Well, I'll brief Dana on our discussion here and see what her suggestions are of seeing how we can maybe make that happen and bring our comments forward to the protocol writing group. I have a note here on diversity, equity, and inclusion. I think I just included that just because I think, as VA, we can really contribute to SWOG in a huge way, because so many of our academic medical centers don't always have I think I'm maybe thinking more about the University of Colorado, that when we look at our ethnic table in our continuing review forms, it's an amazingly white group. And that, if we include VA, we can really enhance diversity, not only from an ethnic point of view, but also a rural point of view. We have a lot of CBOCs, and within our visit alone, places that don't get coverage, like Fort Harrison, Montana, Cheyenne, Wyoming, Sheridan, Wyoming, that just don't have great coverage. So I think that's just an advertising point. So with that, Sarah, if you're ready, we can go to the VA and SWOG accrual report. Can you do that for us? I don't know. She's got a 4-month-old at home, so there may be an emergency.
Steve, can you hear me?
I can.
Yeah, this is Leslie. I had sent all of our materials for that to Courtney, and I think she was going to compile those. There we go.
Yeah, they're on the screen.
Yeah, there you go. And I think my portion of this begins this part of the presentation. So let me just go through this.
Okay, thanks, Leslie.
briefly. So what you'll see is the same type of report that we've looked at in the past. It shows all of the different VAs and what their accrual has been this past reporting period. This time I also went ahead and added 2 extra columns so we could compare, if you, just for your interest, the fall 2021 and spring 2021 accrual information for those sites too. I think a lot of this is just a comparison to see how COVID mainly has affected sites. But if you slowly scroll down, and if anyone has a question about any of these sites as we go through, then certainly say something. But I think they've all stayed fairly stable. I don't know if stable is the right word, but there hasn't been too much activity, I think, in change. And some of them have gone down a little bit, maybe some of them gone up a little bit slightly. And as far as accounting for this, I'm not really sure how to, except for what has been called, I guess, what that great resignation. I don't know if I'm using the right terminology. But what I've heard from others in some other meetings is that accrual has been very difficult because of primarily staffing issues, staff attrition. And when folks leave, then you've got a handful left to retrain the new people coming on. And I've also heard in some of the other meetings that many sites have had to work around that, as far as putting trials on hold, not opening new ones, and so forth. So I think that might explain, personally, in my view, a lot of the accrual issues that we might see here. Towards the bottom, you'll see also there are 3 institutions that had been hanging on for a while, being considered whether they would withdraw from membership or not, because they were not on the CIRB, and the decision had finally been made to officially withdraw them. So those 3 sites at the bottom there have officially been withdrawn from SWOG membership. I don't know if anybody wants to speak on any of that. Again, these are just statistics for the last 3 reporting periods for your information.
So those bottom 3 that you're talking about, they withdrew primarily because of NCI Central IRB membership issues?
Yes, I don't think they ever got on it. And there was a lot of push trying to get them on it. And I don't know what their issues were that they didn't get on it. I'm thinking maybe staff, maybe the sites were too small. And they didn't have enough staff to support even before COVID hit. A couple of these have been on the list for quite a while, as far as not obtaining the CIRB. And so they finally dropped off. The next slide coming up shows 3 that we still have that are still pending. They're suspended because they have not gotten on the CIRB yet. Maybe there's a second. This might be a second slide set that would be coming up next after this one.
Yeah,
so
that might be on the PowerPoint.
Yeah, this was the, well, that's not it, but it's all right. There are 3 sites that have been on the pending list for a short time, a while. They're with Kansas City VA. And the site is trying to work with them still to see if there's any chance that they may be able to have enough support staff to be able to join CIRB and do some trials. I don't think it's looking very positive, but they are still trying to work with those sites. So those would be 3 sites under the Kansas City VA.
Yeah, I think that's something, as a committee, we can reach out to see what the issues are, whether it's staffing or regulatory reticence at the site of.
I can speak to that.
Okay, great.
Yeah, so I think the main issue is staffing.
Okay.
And so if that, what I saw that if that grant to apply for hub and spoke model, the Kansas City VA can be the main hub, and all the sites can be the the spokes so we can provide assistance and IRB support and things like that, because we had that model written up as a when we apply for Navigate to try to open those 3 other sites. Our staff now actually goes to the Topeka VA, and so they definitely then can staff and put patients there. The Leavenworth VA, they lost their medical oncology, so they don't have any other medical oncologists there. So all their patients are now being referred to us in Kansas City. The Wichita VA, they have a contract with a private practice person that goes there a few times a day to see patients there. But they are very interested. We have approached them in the past to open studies, to enroll patients, but we need staff. That's the bottom line.
Okay. Yeah, that's good to know, because it can be one or the other or both. So, and so, and hopefully, the storefront model or something like that could help out.
I think the next set of slides is what Sarah had pulled together, so which was wonderful. So I don't know if Sarah can speak to those, or you'd like to go through those and give your perspective. Yes, there you go.
Steve, I thought you were going to share these.
Oh, the slides are shared. Can you just kind of talk through them quickly?
I can. I have very loud children in the background, so I apologize for that. But it's
That's fine.
Dinner time here on the East Coast. So, so I think it's helpful for us to visualize where all of our sites are across the country. We get on these calls twice a year, or have these meetings for twice a year, but you might not know where all of the sites are located. So I just put together this quick little map to show us where all the sites are, and to also show that I don't know much about geography. I had to look up a lot of these places. So just a quick map for everyone to look at. We're at 31 sites as of now. Next slide. Here are accruals in the time period since our last meeting to the various trials, just to show you what the high enrolling trials are. I know that it's hard to match the colors there to the pie chart, but the top accruing trials were the NCI COVID trial with 27 enrollments, Lung Map with 11, NHLBI MDS with 10, and then EA 8171 with 7. Next slide.
Yeah, I would just like comment on that one particular piece that VA is actually given a study that's fairly easy to enroll. We can do it. It's not impossible, because we're just VA to accrue. If we're given the right study, it will happen. So I think those are good examples that, people aren't just sitting around their office and not doing anything. They will accrue given the right protocol.
Thanks, Steve. This slide shows the number of sites and the accruals in the last time period since our last meeting. I know that COVID is still an issue, but it turns out that 17 VA sites had no accruals since our fall meeting. So my point in this slide is to see what we can learn from those high performing sites, the 5 sites that had 20+ accruals in this time period, and maybe use lessons learned from those sites to help bolster enrollments at our sites as well. Next slide. Again, here's our top accruing trials, and then by time period. So you can see broken down into spring 2021, fall 2021, and spring 2022. And Leslie put this slide together. And this, I think, echoes Steve's point that there are certain trials that are a great fit for the VA, and we do very well when we have the opportunity to enroll into those trials. Next slide. And then this is just a little reflection on how we have been doing over time. Again, COVID factors into this a great deal, I think. But as of our, between last fall and this spring, we've had 71 enrollments into trials across our 31 VA SWOG sites. Next slide. That might be my last slide. Okay.
That's it.
I'm happy to answer any questions on that, or if people would like to see the data in more detail, you can always email me and I'm happy to provide it to you.
And just to comment that, the key components of this committee are really Sarah, Leslie, and Connie, who do so much of the work of putting everything together for our group. And I'd like to thank them for doing all that and putting everything together for this meeting and everything in between. So without any comments on that, we're going to go to the next item on our agenda, which is S2209 with Dr. Chauncey. If you can give us an update on that. It's a previously S2105 and where we're at with this particular study that might be good for the VA.
So I can speak to the study. It's not really, the protocol is not really written yet. So, but it's practically there. And it's at the point where I haven't seen the actual document. So I'm not sure what that means. There are probably people in this room that know more about what that means in terms of when it could be activated. I don't know, were you going to show any of it?
No, we don't have any
There's
slides.
no real myeloma people here, but
Yeah, Dr.
it's for older people and frail people. So over 75 or less than 75 if you have qualified by a frailty score. So I think in that sense, and it's multiple myeloma, which is a common disease in the VA. So in that sense, I think it's a good fit. And I think it's a valuable protocol, VA or otherwise. It's asks good questions, and depending, of course, on the results, it may provide valuable answers. But I think it's a good fit for the VA. Having said that, and there are, you've talked about these things, challenges, and I think there are some, and I can throw those out there just from what I know about the protocol. There's oral drug, which is provided by the companies, and there's IV drug or sub-Q that's provided by the company. And it has been mentioned, and I'm here in Seattle, patients might come from Spokane or Boise or Portland and travel around, and we need to be able to, the simplest thing is just be able to do follow-up visits via telehealth. And so I'm not sure to what extent they'll accept that, and outside labs. And then the other issue is drug distribution. And I've been told, and I don't know if this is universal, but that if they were, say, enrolled in Seattle, that Seattle Pharmacy could send the study drug to wherever they are. That I'm not sure if that's true, but I've heard that. But the parenteral drug is a different thing. And so what that probably means is that if the patient is not going to return to your site at whatever interval they're supposed to receive parenteral drug, then that protocol is not going to work in the VA.
And it's sub-Q though, right?
It's sub-Q, but it's not administered, self-administered. So that could be a deal breaker right there, and that would be huge and really unfortunate. So, that cuts a lot of patients out, and I'm sure that happens in other studies as well. So I think, this study is useful for us to discuss in terms of those limitations. Follow-up drug distribution if it's commercial drug.
I have a few.
Yeah, you probably know a lot more about that, a lot more insight than I do.
Necessarily, there's a lot of things like we haven't completed the contracting yet. The study is just about to go to CTEP for the initial review, not the concept, but the full study review, which normally would mean that we would expect to activate it probably around October, November timeframe. But we are still taking a little bit of time to get to the point of getting agreement with the company on details of how the contract will work. And so one of the questions that came up, so daratumumab is commercially approved in this setting, but because it's an older patient population, the study chairs were really concerned with issues of really high copays across the board. And also Dr. Christine Yee is very she really wants to highly engage with the VA institutions. She's really motivated to do that. So she pushed extra hard because normally our normal guidelines would say if it's commercially available and it's likely to be covered by insurance, we're not going to contract for it because it increases our effort and cost. But because the study team made a really solid plea for why we need to provide drug in this setting, we agreed to go ahead and try to contract. However, the drug company, in this case, really wants control over the distribution process. And so how much we are going to be able to do in terms of distribution may be based on what they will agree to in the contract. And so we have been pushing to allow SWOG to have more control over the distribution, but that's still being negotiated. If we are able to get what we want and use McKesson for the distribution, then we can give guidance to McKesson for how we want them to handle the distribution. And we then have a lot more flexibility for tailoring it. But if not, then it would be the drug company distributing through themselves or through a vendor that they choose that would be using their guidance. And I don't think we would have as much ability to.
Yeah, and when you say, and it's Janssen, right? That's the distributor. Were they wanted to do direct dispensing, or did they want to distribute through like a wholesaler? Or
No, they are being, well, so part of the question is, and we're not quite at that point yet, is the last study we did, the DARA was investigational supply. And so they were really rigid about that. They did not want to give us any flexibility for overtaking any of their responsibilities for drug accountability or distribution. In this case, since it is commercially available in the indication, we won't have to follow all the investigational drug handling requirements. And so that's what we're trying to figure out right now is, does that change what their processes will be? Will they be more flexible? Even if they insist on handling the distribution, maybe it'll be easier than it was on the investigational drug study. But ideally, we would like for them to just pass through that responsibility to us, and then we can use our normal processes, and gives us a lot more room to maneuver. So we're still working on that. And I think that it sounds like there is some, at least willingness to listen. We were really making the plea to them that if we and they agree that diversity is important, which in a myeloma study definitely is going to be important. Right. Especially this one with the frail and older patients, you want to get the patients that are there in the community, not just the academic centers. And so it sounds like they agree with that. And so if we can get them to buy into the idea that if we have more flexibility in the distribution process, we can make it work better, it might work out.
Okay, yeah, because I think as long as it's not direct dispensing to the participants, the VA can make it work.
Yeah.
So I don't think that's a problem for us.
Yeah.
And the high copay, not an issue.
Yeah, yeah, yeah. That's actually less of a problem. I mean, there's some things where it's like, we go in one direction for certain sites and we go in a different direction for other sites. But the other thing is this study will have, when it's activated, it will have PROs in it. It also, shortly after activation, may have an additional economic sub-study and an imaging sub-study and pretty hefty specimen collection. So it's going to be a difficult enough study. We've got a lot of feedback from sites right now. It's simplify, simplify, simplify. And this is another one of those that has the bells and whistles. They're already including them. And then additionally, the coagulation sub-study will be added to it after activation. So it'll be activated, and then there will be probably 3 or 4 quick revisions to add those elements in. The study chairs did not want to spend time working on paying a lot of attention to the details of the sub-studies before they submitted to the NCI. And so we're at the point now where it has to be in the shape that it's in to go in for NCI review. But I think that it sounds as though Janssen is going to be willing to financially support a lot of those elements. So they'll be important, and we hopefully will be able to offset some of the site effort with additional payments.
The best case scenario for
I think probably it would be easier for sites. Our process is that if SWOG is in control of the distribution, we go through McKesson. Is DARA, and I'm just blanking right now, is it oral or is it sub-Q? So
if they were enrolled, say at our site, at our pharmacy,
yeah, that
no matter
is
where they live.
right. And actually I'm trying to think it's lenalidomide. Yeah. And it's commercial supply of lenalidomide. So yeah. So that the other drugs are commercial supply. So we're not getting in the middle of that. So whatever your institution would normally do is what they do. But the DARA is the big ticket item. Yeah. Right.
So would someone have to go to a VA site to have it administered?
Probably so, unless there is an investigator who is a registered investigator with the NCI that's closer to the patient, that there's some kind of agreement that investigator.
This touches on the other things that we're talking about. So
Yeah.
say someone goes to a smaller VA that doesn't have this particular protocol. Could they administer the DARA, or they would have to?
No, well, actually, that's where part of the question is, because if it's not investigational supply, technically anyone could administer it. It's just being provided as so as long as, and I think we're there. It sounds like Janssen has agreed to this, and CTEP has agreed to it. The idea that we're using commercial supply, it's not investigational for the study, but we're just supplying it. So yeah.
Someone's getting it, not
Yeah.
maybe CBOM or something.
Yeah.
That would really-
Yeah, and we could, the NCI has it's kind of like an exemption that if you write it in the protocol, that this is an allowed use of a non-registered investigator, then it's acceptable. And it sounds like we could do that.
Yeah, because
Mhm.
I'm thinking this in IRB terms as well. It's like if you have another provider give this to them and kind of their normal daily activities of what they normally do, they're not engaged in research.
Right.
And so that might be something if we can, and this is something, I think, our group and the myeloma group, we could all.
When it comes back to CBOM, that's something.
Yeah.
Yeah.
And there's, I don't know if Daphne Friedman's online, but she's been doing some work with telehealth from Durham to like, I think Wisconsin or something.
That's the other part of it, is like, Seattle's got protocol, Seattle does telehealth. Should count as a business. Can count as a business.
So that piece is, the NCI has kind of said CIRB has control over what can and can't be used for telehealth visits. And I'd have to refresh my memory on what their policy is. They have widened over COVID what is allowed for telehealth, but there are some things, like if it's a disease assessment, and in myeloma, that's a little different, because they will say, if you're doing lab tests, you can have it done at a different lab. But if it's a disease assessment lab test, how does that? Yeah. So we'll need to clarify that.
Yeah, and it might be something worth talking in a broader sense with NCI Central IRB about VA as, the largest healthcare system in the United States, that we can do some things that other folks can't.
Right. And you're accustomed to doing them. That's
Right.
That's the thing, is I think that some of the fears that the CIRB had initially when everything shut down for COVID was they didn't want to open it up and just say telehealth is fine, because a lot of sites didn't have any experience with how best to incorporate it into their practices. But I think there are a lot of things that the VA has more experience with, and the CIRB might be willing to say, there are certain exceptions.
Yeah, or, and we can provide, proof that we provide this level of care, that, the level of care doesn't diminish just because we do it via telehealth. Because I think I heard, we were on a call actually with NRG yesterday. There's something about I think Visinten's going to set up a virtual medical center.
Oh, wow.
So,
We can't move beyond our brick and mortar institutions.
Right, and I think, for all the horrible things about COVID, some of the one good thing is that we've, kind of broken out of our shells, so to speak, that we can get, maybe do more things remotely than we really thought we could. And people are accustomed to those things now. We were forced into Zooming and having a room not very full of people, but having a Zoom room full of people. So.
Get a discussion going about what they think is doable study.
And we can talk to some of our telehealth people and see how we can, maybe work on doing some things that may be a little more innovative than NCI's used to. All right. The next item on our agenda is the VA storefronts, and I don't really want to show we do have the proposal to show on screen. We've sent this to the Hope Foundation and Dr. Blanky of transitioning what's been our VA integration grant award that we initially started some years ago, of doing 5 individual sites at about $25,000 a year, just to kind of give them a little seed money to get going. And that had been very popular, and a lot of those sites that you saw on that map were kind of started that way. And it was actually the seed for the Navigate program that came kind of extended from our success of the integration grants. A couple of years ago, we transitioned that. Instead of giving 5 grants, we went to 2 at $50,000 a year. But the applications have certainly slowed down for that program, and that particular need or approach to solving that problem may have lived its best life, and maybe it's time to move on. And we do have the Vision One storefront, which Sarah and others in Boston started around 2013, 2014. And we'd like to maybe transition and see if we can get the Hope Foundation to allow us to transition that grant to funding another storefront. So we can do a bunch of the things that Dr. Wong was talking about, not eliminating, but reducing the regulatory burden, providing some of these things that the Vision One storefront does with their sites, which now is, I think, up to 11 or 12 sites, not all in Vision One. I think Seattle actually is one of the storefront sites out of Vision One. And because we think we actually need about 4 of them, but if we can get one through the Hope Foundation, that'd be great. And then maybe we can find some other funding for the other 2. But the idea there that we would fund a storefront for up to 2 years to get them started, hopefully self-sustaining after that point, and go from there. So did anybody have any comments on that? I mean, I wish we could ask for more storefronts, but we're estimating 150K a year. We think that'll do it. It's, I think it's going to depend a lot on the application and what they think they need. I think we could fund them up to 150,000 a year. I know at one of the last Navigate meetings, Dr. Blanke asked, what our thoughts were for moving forward. And we mentioned at that point too, that, we wanted more storefronts so that we can, take those smaller places like Cincinnati and stuff that kind of dropped off the map and bring them on board, help them get on with the NCI Central IRB without a whole lot of staff involvement, overcome any kind of regulatory hurdles that they might have. And then also help them with, a bunch of things we were talking about earlier in the meeting, and, understand the protocol, getting the stuff through the NCI Central IRB, other things that could help move it along and get accrual, and not have to be a full member that has to have 10 accruals a year and everything. So it would all go through the storefront. Any comments from those online? Questions or comments?
So this was I was asking that we could potentially implement that with some of these, the VA being Kansas City being the hub and some of the satellite VAs being the spoke. Is this going to be open for application soon, or
I'm waiting.
Just a proposal at this point.
Right now, I have not heard back from the Hope Foundation or Dr. Blanke one way or the other. They've been very accommodating otherwise, but we'll have to see what they think about this. We think it's a good idea, but we will announce it if it becomes available, if we transition from the integration grant awards. So.
Thank you. That'll be helpful.
Yeah, at least as much. I think, we've definitely, just from our personal experience, a lot of our research coordinators, oncology and not so much in oncology in our setting, but a lot of the non-oncology ones, there just wasn't work for them to do. And so they transitioned out. And, if you weren't doing a COVID study, I mean, we were able to bring some folks in for those, but, if you weren't doing a vaccine trial or a treatment trial in COVID, there wasn't a whole lot left for you to do or come into the medical center. So.
I was just thinking that might be an additional rationale that putting Western for a grant, that by centralizing a lot of that support, you're actually taking, the bulk of the burden off that they have more difficulty.
Yeah, we kind of put that in there, but I don't think we put it in the context of COVID. So that might be good. And certainly, kind of the remote aspect of everything these days. I think when the storefronts first started, the kind of remote collaborations that we have now are not the norm by any means. And there's the Cancer Moonshot 2.0. I don't really have any information on that. I don't know anything how that's going. I think there's stuff coming up. I think VA is involved with that, but I don't know anything more than that. So, and then item F here, additional efforts to collect and share SOPs. I think we kind of addressed that earlier on, that, you know, maybe this Teams concept or a listserv, although Teams might be easier to share files, and although that we have so many teams now that can get a little bit messy. But we'll definitely look into that, and that I think Navigate has always been willing to share what they can in terms of their a lot of the work they do. That's really been helpful. And kind of on this same thing that I mentioned, that we had a conversation with NRG yesterday. There's actually, NRG set up a committee or work group, or I don't know exactly how they label it, similar to ours, and they're just getting started. And we had a conversation with them yesterday and shared some of our successes, and we're going to have some ongoing conversations with them to collaborate with NRG on the VA side. So I think that's, we just need to get 2 more groups and we'll have the whole team. But I think that's really, I mean, they were really, I mean, Sarah can speak to this. She was on the call, and Colleen from Boston as well. And we talked about, you know, the storefront thing we've done and that we want to do more of, putting members on committees, and that sort of thing. So hopefully that collaboration will bear fruit. Maybe I'm really hoping it helps with some of our SWOG trials too, in terms of the RT component of sometimes when we have trouble with it, not trouble, but difficulty complying with the RT component, and have some collaboration with our academic affiliates where we don't have RT in place at the medical center. So any other, I mean, that's all I really have. The final item of other business is how to transition out of COVID into pre-COVID life. Dr. Chauncey, did you? Yes. Yeah, I think we're all just maybe starting to get a feel of normality again, or at least the new normal. And so I think, again, maybe the Teams thing, we can all think about, you know, ways to reinvigorate ourselves and get back out there. I know it's certainly nice to be back out again. Although during my time during COVID, I never had to quarantine because they made me come in every day because we were doing vaccine trials and treatment trials. So, but I do miss COVID traffic. COVID traffic was great. Any other comments from anybody online in the room? Questions, things we should address that weren't brought up?
So for the next meeting in the fall, is there something you need me to address with the lung cancer committee, aside from the things that we discussed?
I think maybe just follow up from what you've started, and maybe
Okay.
we can get some more data. And then, yeah, let's think about it a little bit, and you know, what we can do better.
Okay.
And,
so the survey is still open. We only have 15 respondents. So any of you who haven't responded to the email, if you would like to participate, please do so.
yeah, that'd be great, because the more information we get, we know what, you know, where the pain points are, and we can try to address those. We can't address everything, but we can figure out the things that we can really make an impact on.
Absolutely. Thank you.
All right, so that's all I got. I mean, we're a little bit early, but I think that's okay. It is Friday afternoon after all. Thanks, everybody. Thanks, everybody online.
Thank you.
Thanks. Bye-bye.